Hi everyone, I hope you're doing well. My name is Ekta and I'm a second year podiatry student and I study at the University of Northampton. On the side, I like to interview podiatrists and podiatry students for your entertainment and knowledge. Every week, I interview a podiatrist who helps students like myself gain some insight into the podiatry world. So, if you're thinking of becoming a podiatrist as a career, then I think you'll learn a lot from watching my videos. This week, I interviewed somebody incredibly special, Mr. Howard Dananberg, who invented the sagittal plane facilitation theory. Not only that, but he has quite a list of accomplishments, so let's take the time to read them out. He graduated at the Ohio College of Pediatric Medicine in 1975. Just want to show off my cool phone case. Okay, back to the credentials. He's a fellow at American College of Foot and Ankle Orthopedics and Medicine. He's a contributing editor to the Journal of the American Pediatric Medical Association, JAPMA, if you are familiar with that. He's won the Astor Award in 1986 for initial paper on functional hallux limitus. MIT Lemelson Inventor of the Week for Insolia Scholes Award for Outstanding Clinical Paper published in JAPMA, which I just mentioned earlier. He's a founding member of Vasily Think Tank. And he's published numerous papers and provided over 100 lectures worldwide to podiatry, physical therapy, osteopathic, and medical audiences. He's now retired. He retired in 2012 and now resides in Stowe, Vermont. Anyways, I really hope you guys enjoy the video and I hope you learn a lot from this interview. It's super, super cool. If you like my videos, please hit the subscribe button, click the like and notification bell so you get updates anytime I upload. I try to aim for Fridays, but definitely once a week. Thank you so much. Enjoy. Okay. Hi, Mr. Dananberg. How are you doing today?
I'm just fine, thank you. Nice to see you, Ekta.
Nice to see you.
Glad to give you this information to you and your students. How many students log on to your webpage or your
So,
YouTube channel?
as of yesterday, I'm up to 50 subscribers.
Good for you.
So, I'm really happy about that, and I'm sure all my classmates watch, and they're very, very keen. Fingers crossed.
Yeah.
Um,
Where are you in school?
so I study at the University of Northampton, and
Mm-hmm.
we have 25, 26 classmates in our cohort for
Mm-hmm.
2019, 2020.
Mm-hmm.
And we were covering the foot functioning paradigms. And we came across sagittal plane theory, and I was like, oh my God, I don't understand. It's just such a, it's a great, I love it. I don't think I've understood it yet. So I thought it would be great if I could reach out to you
Sure.
and get a firsthand account of, first of all, who you are, so how you came across into podiatry.
Mm-hmm.
When did you first find out about
Well,
podiatry?
I was an undergraduate student.
Hmm.
I mean, when I was in school, it was a long time ago. It was during the Vietnam War.
Oh,
And so I was deferred from military service because I was in college.
yeah.
And then someone told me about podiatry, and I looked into it, and I said, "Wow, this is really for me." I did not want to deal with people living and dying, so that
Mm,
wasn't something that I wanted to do. I looked into optometry, but that was just making glasses. That didn't seem interesting enough to me.
yeah.
I didn't know about chiropractic, which really was not a big profession at the time. That would have been pretty interesting to me. But when
Mm,
I found out about podiatry, it was like, wow, this has everything I want. And so I went to visit a podiatrist, and it was a Saturday morning, and
mhm.
he was working, and all these guys and women came in to see him. And they limped in, and they, were happy to leave, and everybody was patting everybody on the back. And I went, wow, that's a nice way to make a living. That looks like a good time. And it was. And it was. I practiced for 40 years in New Hampshire, which was about an hour north of Boston in the
Okay.
state. Um, and I had a great practice. I had people from all over the world that eventually came to see me, and it was a lot of fun. I really enjoyed it. And I think the interesting thing about podiatry to me was that during the 80s, I my brother was a resident. He was going to be an endocrinologist, and he said, "Hey, I got surgery rotation this month. I hate that." And I said, "You hate it? You hate surgery? You're allowed to hate surgery?" And he said, "Well, yeah." And I went, "Oh, okay, good." And then I was already very into biomechanics by that time.
Yeah.
So that sort of took me on a different road and away from the surgical cases and more into the biomechanics of things and pressure analysis and that sort of stuff. I was one of the first users of the electrodynagram machine, which was a Langer biomechanics invention. And that was fascinating. And I learned a lot from that. And I really was like a big time student of that and really obsessed over it, actually, to be quite frank. And because it didn't, the more I looked at it, the less I understood.
Yeah.
And certainly in terms of Rude and those guys who I knew, not then, but after the fact, I certainly read their stuff and heard all about it. But it didn't match what I was seeing on pressure. Not that I knew what I was seeing on pressure in the beginning. Eventually it made sense.
Right.
But, but over time it was like, how does this work? So I'll tell you the story of the first person that I identified this with, and which was a fascinating story. So I had this electrodynagram, and there was a story in the local newspaper, and a woman called for an appointment.
Mm-hmm.
She came in to see me, and she was in her 60s at the time, I guess, and she had 40 years of pain in the front of her leg.
Okay.
And only at night, but every night. And I was the 13th or 14th doctor she had seen. No one knew what was wrong with her. No one knew what this problem was.
Mm-hmm.
And I examined her, and there was nothing really like that jumped up out of the exam.
Right.
And so we did this electrodynagram, and even the gait exam looked pretty normal to me. But some of these things are very subtle, and that's what I couldn't see. So on the electrodynagram, on one step, and this was a left-sided problem, on one step, the left hallux took 4 times her body weight. And the next step, it didn't touch the ground. And the next step, it took 4 times her body weight. And the next step, it didn't touch the ground. And I looked, and my first thought was, the stupid machine's broken. It's really what I thought, because it seemed so odd,
Yeah.
I watched her walk again, but this time I was looking for something very specific. And what she did is she just inverted her foot every other step. She took it and she turned away from the toe, and I could see the anterior tibial muscle firing.
Mm-hmm.
You see the front of the leg. It's pretty easy to see, and it's really a swing phase muscle, not a stance phase muscle.
Yeah.
And she did every other step for the whole stance phase. And I went, and that's where her pain was the anterior tibial muscle. And I went, oh, she's overusing that. I wonder why. And then by serendipity, I just was playing with her foot, and I went to dorsiflex her MTP joint because it was normal.
Mm-hmm.
No complaints of pain, nothing. But as soon as I loaded it, there was no range of motion. And as soon as I let it go, it moved. And as soon as I loaded it, it was no range of motion. So it was like, I said, like, she's got hallux limitus, but she doesn't have hallux limitus. The joint moved normally.
Yeah.
So I had been playing with treating hallux limitus, the arthritic type, for like a year or so at that time.
Yeah.
And was getting pretty good outcomes, and had played with first rate cutouts a little bit and started to understand that. And then, so I taped her.
Okay.
And she came back in a few days and said, I haven't had a symptom since she did that. So made an orthotic and completely went away. And I remember that day leaving my office to drive home and thinking, wow, she's compensating for something that doesn't hurt her. How odd is that?
Yeah.
That was my first thought. And then the next day, everyone who I had treated as a pronator had this. They had this locking of the toe joint. And I went, wow, that's odd. And then I had a patient who was a lawyer in my area, who I knew was a really good guy. And he'd been to every podiatrist around the country, including me. Not every, I mean, he went to all the top guys, Steven Subotnick and Richard Schuster in New York. And he'd been around trying to solve this problem. Mm-hmm. And I had made him orthotics, which didn't work either. And I called him. And it was like, I hung up the phone and he was there. I mean, it was like, it just seemed that he was so fast. He just came over. And all I did was take his orthotic and put a first rate cut in. And he stood up and he said, that's it. He knew right away that was what was wrong. And then I would only see him once every 5 years to replace his orthotics. That was it. And the guy ran marathons and he did all kinds of stuff after that.
Wow.
So he was doing really well. And it started me on a course, a mental course of like, wow. So this is not about the rear foot. This is about the forefoot. What does that mean?
Yeah.
And that's how this developed. So I think I want to do is, starting now, I'm going to share my screen with you so you can see the two slides that I put up. Okay, so let me go to this mode. Okay, and let's do that. Okay, so I'll move you out of the way. So let's start with this. This is a chart of phasic muscle activity during walking. Okay. I mean, these are very standard things. They're all over the internet. They're easy to find.
Mm-hmm.
The first thing to look at in this is, let's look at the gluteal muscles, which are the muscles in your backside, right?
Mm.
And those are classically considered to be extensors of the hip. Okay.
Yes. Yeah.
Right. Okay. So look when they fire. They fire at heel strike, and by the time the thigh begins to extend on the hip, look what happens. The gluteals are off.
Yeah.
They're not on. And the time when the hip extends, they're off. So the hip is extending without muscle activity. What is the muscle doing? Well, but the muscles work in two ways. They resist lengthening, or they shorten. It's one of the two.
Mm-hmm.
Turns out resisting lengthening is 6 times more efficient. Well, between 1.5 and 6 times, depending on what literature you read. Let's say 4 times in the middle. And so the body knows that, even though you might not have known that, but the body knows it, and you've walked around, so it knows how to use that. And what it does is it fires to prevent the hip from collapsing at heel strike. It supports the hip. But as you extend your limb, that's not what's extending the limb, because that muscle's clearly off. And when you get to the toe off phase, look, the gastroc is even off. I mean, you have no calf contraction. Muscles support the limb, they don't power the body. If you power the body with the muscles, you'd be exhausted in no time. Walking is highly efficient. People can walk all day long, and have jobs as, mailmen and postmen and waitresses, and, they're on their feet. They work in factories and warehouses, and they walk all day long. Well, if you were concentrically contracting your muscles, you could never do that. So how is it that we move? I'll show the next slide. So this is a graph of a pressure graph that shows when we move. And the graph, the black line that goes like a wave on the top, that's a classic force to time display of body weight when you're walking. So at heel strike, which is the first peak, okay?
Yeah.
Let me move my cursor here. This peak right here, okay? That's the first peak. That's when you reach your maximum load from heel strike.
Okay.
And look at the bottom, because the gray areas on both sides are peak AP is anterior posterior, so front to back. Peak AP braking. So when you hit the ground, you're slowing. And walking is slowing and speeding and slowing and speeding, and you develop an average speed, but it's not constant. You slow down and speed up and slow down and speed up. And so you hit the brake, you slow down, but then you have to overcome that braking, because here's what happens. The red box is single support phase. Humans walk by pulling, not by pushing. The power is in the swinging limb, not the standing limb. Okay. So you step forward. In fact, if I said to you, I have to stand up and walk to the other side of the room, the first thing you would do is step. If I said stand up and walk backwards, what would you do? You'd step backwards. If I said move to your left or move to your right, you would do that too. Because what you do is you destabilize your center of gravity, which is somewhere between your belly button and your spine. And you destabilize that. The standing limb is supported by the muscles resisting lengthening. That's very efficient. And so you use it as a lever in any direction you want. Now this is forward walking, and you could see that you have braking initially, and then you overcome that braking right in the middle of the step where the gray becomes black. And then you could see in the bottom of the graph, that's the acceleration. Look when that peaks. That peaks when the other foot hits the ground, because when the other foot hits the ground, it's braking just like it did on this one. So you're speeding and slowing. So the speeding is happening in the middle of the step during single support phase. That's when you move. You don't move when 2 feet are on the ground. So the whole idea of propulsive phase of gait is wrong. It makes no sense, because you're braking then. You speed up in the middle of the step. That's pretty obvious.
Okay.
And so what you do is you use the muscles of the swinging limb to pull yourself. Think of it being a kid on a bicycle, on a swing. You kick out to pump your legs to go higher and higher, and and you swing yourself and you use your legs to pull your body forward and
Yeah.
pull it backwards, right?
Mm-hmm.
That's exactly what happens when you walk. And so as you step out with one leg, the other leg extends out from under you. And then when the forward leg hits the ground, the back leg actually collapses and accelerates into what's called pre-swing phase, and then toes off, and then you have a normal step. And so the swing limb is really what's pulling you.
Okay.
Rather, it's the active one. The stand side is the passive of the two sides, okay? So this is a video that I've shown all over the world many, many times. And watch this. So this is a girl who has very flat feet, but notice how when she toes up, how the arch raises. I mean, that's very clear and obvious, right? Yeah, it's a Windlass effect, right? Do you know what that is? The Windlass effect?
Yeah, we just learned about it, where you pull the first ray and the arch kind of tightens.
Well, not the first ray, you pull the hallux.
The hallux, sorry.
Right, well, big difference, because the metatarsal has to plantarflex and the hallux dorsiflex, just like you see in that picture, okay?
Yeah.
And so even when you think of hallux liminis, which is arthritis in the toe, watch what happens as she raises up here. It's the toes. Has the toe moved? No, the toe's stationary on the ground. What's moving is everything else around it. And that is what becomes so critical in understanding how this works. It activates the windlass. The windlass was described by J.H. Hicks from Great Britain in 1954 in the Journal of Anatomy. I would highly recommend that your classmates read his 4 articles. It's called Mechanics of the Foot, Part 1 to 4. They're very short, they're very simple, and they're very brilliant.
Okay.
And they really, really explain what happens when you walk and what the foot does and doesn't do. There's a lot of information in there, and I think you'll find that very, very valuable. So that's her standing, but watch this one out. This is the same person, but now she's walking. And watch what happens. She has normal swing phase. The heel is pulled up, but notice what happens. She can't bend at the MTP joint. So she moves at the mid-tarsal joint. And pronation occurs at heel off, not heel contact. The whole idea that pronation is related to heel strike, I think, is wrong. And I don't think that's what it is. I think it's the sagittal plane restriction that causes you to lose the ability to step over your foot. And so you have to adjust. Now, keeping that picture in mind, well, let's look at this. So with respect to the body, I mean, if you're walking forward and trip over an obstacle, what's going to happen? You're going to fall forward.
Sure. Yeah.
Because momentum is going to continue your body going forward. That's what it does. Momentum is a big part of walking. That's my dog barking. It's a big part of walking. So now, thinking of that, but we don't fall like that every day. I mean, we do fall, but it's very controlled because you reach that peak, that double hump curve that you saw. The low point of that is when you're at the highest point in the step, and then your body weight is being pulled to the ground, and body weight in the swing limb is what drives you. That's what makes it so efficient.
Okay.
So, but when you look at this picture, so you have, what you want to see is you want to see the picture on your left is efficient. The heel is off the ground before the opposite limb strikes the ground, and you stand up tall, because that's what the windlass does. It tightens the fascia through the entire body. So you stand up tall and you walk straight. But if you have this functional limitation at the toe joint, or it could be at the ankle joint, which you talked about, and that it could be both, and either or they can both be a problem. Slowly over time, and you become to look like the picture on the right, where you have a flexion response, the head's down, the spine straight. You barely lift the heel during single support phase. Your stride length is short. You don't extend the hip. You begin to move very slowly. Walking is a lot like riding a bicycle. When you have a resonant pace in the bicycle, you have balance. They're gyroscopes, and they stay balanced as long as the wheels are spinning. Well, we have that similarly when we walk. And so, but the slower you go, the more balance becomes difficult. So in geriatrics who have a hard time walking, and they walk slowly and put one foot in front of the other, their instability is often related to the speed of their gait. One of the most rewarding things that I treated when I was in practice was taking patients who were unstable and making the right pair of orthotics, because once you make the toe joint bend, heel lift becomes easier and the whole system activates. They stand up straight and they start to walk twice as fast. And it's instant. It's so rewarding. It's instant to them. They just stand up and they start to move and they feel better balanced. It's wonderful. And that's what this is about. That's what sagittal plane function means. It has to do with the MTP joint and the ankle joint, and the ability of them to allow you to step over it while the rest of your body is being moved by momentum and the other limb kicking out. That's the secret of it. It's not the muscles of your leg driving you. It's the rest of your body driving you, and the foot needs to respond to that. And that's why I said the swing limb is active, but the stance limb is passive, and it needs to react. If it doesn't react, pronation that we see late mid stance, the bad one, occurs in the second half of the step. And that is directly related to what I just talked to you about. So I'm going to unshare my screen. How do I do that? I go back to this. I think just escape. Yeah. Stop sharing. There we go. Okay. So that's the explanation of what sagittal plane function is. Yeah. And it's really about the Windlass effect. I mean, read Hicks's original articles, because without reading that, you won't understand what he really talked about. You'll see somebody else's interpretation of it. But reading his originals will be very helpful to you.
That's actually really good advice. I'm gonna write that down. So moving on to the next question.
Yeah.
How do you feel about the other foot functioning paradigms?
I think that they all have some value to them. I mean, I knew Mert Root. In fact, it was one of the heaviest biomechanics discussions I ever had with anybody. I hung out with him for 4 hours one time in his house.
Oh, that is super cool.
Yeah, it was super cool. That was a long time ago. He's been deceased for a bit, but and we got along real well. I mean, he liked what I said and what I thought about, and Tom Scarlato really liked what I said, and the other fellows that work with him, really John Weed, and they're all deceased now, but they like this. They like the idea of it. I think that it's very important to think about how the whole body is involved with walking. And I think that a lot of the other paradigms miss that. They don't look at the involvement of the body. They look very foot centric, you know. I mean, I mean, I know Kevin Kirby, and I like him a lot. One of my favorite lectures he gives is called 10 Reasons Not to Cut the Plantar Fascia. I mean, Kevin is a good guy, but I think you have to apply, when you look at the subtalar joint axis theory, it focuses too much on the foot and it doesn't look at the center of body mass moving over the foot. What's that influence? How does that? I think that's what this represents. So.
Okay. So more of a holistic.
I think it's not so much holistic as much as its whole body. That it looks at the involvement of the body and how the arm swing and changing arm swing makes such a big difference in how we move and how we operate. You know, I mean, from scoliosis to chronic low back pain to migraine headaches, all those things are connected. They're related, and when you start to see those pieces fit together, you begin to see that if you just let feet do what they should do, which is pivot at the ankle and pivot the ball, the MTP joints, that it all happens by itself. You don't have to do much. Swing phase is a neurologic constant. You pick up and take an infant and you pick them up by their arms and they step. They already have that built in. The swing phase is what we're given. We learn balance and stance and support. That's what we learn. It takes us time to walk, to learn to walk. But swing phase is there, built in, and there's a reason for that because it's so important in how we walk and move. And that's why treating patients with, you know, like severe neurologic disorders like cerebral palsy or you know, any of those things, swing phase is abnormal, and now all of a sudden gait becomes much more difficult.
Interesting. That was really good.
What'd you expect?
I don't know. This is the coolest interview I've done so far, and I hope none of my other guests are offended by it.
No, no, they
Just a
shouldn't.
little
I mean, come on.
starstruck.
Don't be.
Do you have any advice for students?
I do. First of all, I thought about that, and I have a great advice I'll give you at the end.
Okay.
But since we're talking about mechanics, I remember when I was learning too. I mean, it was a long time ago, but I remember it distinctly. And having them say, "Ooh, do you see that? Do you see the pronation? Do you see the heel lift? Do you see that?" And I would say, "Yeah," and I didn't see anything. So it takes a long time to be able to really be good at gait analysis. I recommend, video cameras and slow motion and that kind of stuff. I just did a meeting in New York. I did it from this same room because everything is Zoom now because of COVID. The chairman of the meeting is a guy named Joe D'Amico, who's the chairman of the New York Podiatry College and biomechanics. And he said if he had one piece of equipment that he would recommend everybody have, it's in-shoe pressure testing. I mean, I still use it for other stuff that I'm involved in, and it's very, very interesting. It really gives you a very different insight as to what's moving versus what's not moving. It's all about the shape of the curves that you saw, but they level out and they show you whether movement is occurring or not occurring, and that's really what's happening. And where pronation is a bit of an illusion. And it is. It's not. It's happening, but
Yeah.
why it happens? Because you can't see what's not moving. You can only see what's moving. So it's hard to see what's primary versus what's secondary. But the advice I'll give you at the end of this is this: that especially as podiatry students, or a student of anything, quite frankly, there are times in your life that you'll have decisions to make. And where do I go work? Do I do a training program? Do I set up on my own? Do I work with somebody else? Those questions. And it's very hard to decide. Well, you can make a list and you could put the pros and cons on either side, but sometimes people will second guess themselves and say, but if I did this, then I did that. And so here's the advice. The advice is that do whatever you want to make the decision, but once you make the decision, know in advance you'll never look back on it. That you will work as hard as you can to make the decision that you made be the right one. That's my advice. And it's very simple, and it really, really makes a difference in life.
Yeah.
And it is, once you know that you're not going to second guess yourself, the decisions become 100 times easier. I learned that when I was finishing my I think before I was almost graduated. And it was right before I was going to either do a residency or go into practice. There weren't that many residencies at the time.
Okay.
But I had the opportunity to get one. I didn't know what to do. And this guy, and I said, well, okay, I'll wait a year and do this training. And it was very worthwhile. But I remember learning, it was a guy named Robert McGregor who practiced in Boston. He was at the Deaconess Hospital, and he gave me that. And it was the best advice. And it really, I've used it my whole life. Whenever something had to come up or had to make a decision about something, I'd weigh it, I'd be careful about it, and I would be thoughtful about it.
Yeah.
But then I would never look back on it. So that's my advice.
Oh, this is great. And that actually answers my next question, which is, what's the best advice you've ever gotten? And I feel like that's going to be the same answer.
I think that there's a lot. No, I can give you different advice. I have something else that happened, that the best advice I ever got. That was one of them.
Okay.
The other one, so this is a little different. Hopefully nobody will need it, but sometimes you do. So when I was, right before I finished podiatry school, I found out that I had this very rare tumor in my head. That was, it was called a pleomorphic adenoma. It grows above the soft palate. I've had 3 surgeries for it over my life. I don't think I'll need them again. I'm too old. But it was, when I first got, I mean, it's a very rare condition. There's very few cases in the United States. Maybe there are 10, 12 a year. It's really unusual. So when I first had it, I mean, it's a big tumor growing above my soft palate. No one knew what it was.
Yeah.
And I was very upset by it. And I went to see, for a second opinion, I went to see a doctor at Case Western Reserve University because I was in Cleveland, that's where I went to school. And he, and he was very kind and wonderful guy. And he said to me, I was very upset by this, needless to say. I mean, I didn't know I was going to die. I mean, like it was very serious. And he said to me, look, you're graduating school in a few months. you know, you know that people get sick, they get cancer, they die, things happen. He said, don't waste your time. Accept that it happened to you and move on with your life. And it was such wonderful advice
Yeah.
that I can't tell you the peace that I got from that, you know, PEACE, that I got from that,
Yeah.
and how wonderful it was to be able to realize how A, you have no control in life, and B, how much control you have in life. I mean, it's both, you know, and you
Yeah.
can, because, you know, famous Amos once said, there's no such thing as a good experience or a bad experience, just an experience. And how
Yeah.
you deal with it makes it good or bad. And
Yeah.
so, and you learn to cope. And coping is sometimes, I mean, things happen. Life could be crummy, and you know, they could be very challenging at times,
Yeah.
and surprising. You know, like look what we're going through now with this COVID nonsense. You know,
Sure. Yeah.
it will be
Absolutely.
over in six months. Life's going to change again. I mean, it'll take a few
Yeah.
years to straighten out again, but
Yeah.
vaccines will be there. Everything's moving along. Looks really kind of promising. And but you'd be surprised how much you're going to cope. So I'll leave it at that. How's that?
That's fantastic. Thank you so much. Again, thank you so much for taking time to talk to me today. It's been such a
Yeah,
wonderful experience. I will remember this for the rest of my life. This is amazing.
I'm very glad. Thank you.
Thank you.